Yes, Ritu.
So, ma'am, shall we start?
Okay, just a small prayer. Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pashyantu ma kaschit tupat bhave. Na tvam kame rajyam, na swargam, na punarbhavam, kame duktaptanam praninam arthanashanam. May God give light and help us to cure diseases and take away the darkness of ignorance. Yes, you may start, Ritu.
Thank you, ma'am. With the blessings of the Almighty, we are starting the session for today. Good evening and welcome to one and all. I'm Rituparna from Clarinet, the designated session assistant for a seamless experience, and Clarinet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Clarinet is very proud to be a digital partner for this event named Management of Early Stage Endometrial Carcinoma with Preservation of Fertility, organized by the Oncology Integrated Society in association with Dr. Chaturvedi Cancer Hospital and Research Institute, Gorakhpur, Uttar Pradesh. So without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Deepthi Chaturvedi, Gynecologic Oncologist and co-proprietor of Dr. Chaturvedi Cancer Hospital, Gorakhpur, Uttar Pradesh. Over to you, ma'am. Please proceed.
Yeah, as we know, endometrial cancer is one of the least prevalent cancers among the cancers in females in India. But it is a cancer of West. But still, we have to take into consideration many things, high-risk factors, genetic causes, and the causes which can be avoided. The statistics say that the prevalence of the endometrial cancer in US is around 25.7 per 100,000 women per year. And the lifetime risk for developing this disease is approximately 2.8% in American women. In India, the incidence is 4.3 per 100,000 women with a cumulative risk for the diagnosis of 1.71%. Approximately 40% of these new cases occur in Asia, with China, where endometrial cancer is the third most common female malignancy, accounting for nearly half of the cases. So we know the underlying cause is not the stress alone, but also a genetic predisposition to tolerate stress. And for that, we have experts with us, the chairperson and the speaker. Chairperson is none other than Dr. Amrita Jaipuriyar. She is the president of Foxy Gogs Gorakhpur Obstetric Gynae Society. She is the consultant Gynae and Obstetrician Jaipuriyar Medical and Research Center, Garg Hospital, Gorakhpur. Jaipuriyar Medical Research Center, Garg Hospital, Gorakhpur is a present affiliation. And she has many major achievements to her credit. Qualifications, as everyone knows, she's MS and beyond that, DNB and FICOG. Her present posts are President OBGY Gorakhpur, Treasurer Gorakhpur Menopause Society, Secretary ISOPAV Gorakhpur Chapter, Organizing Secretary Workshop, Maternal Mortality, NZYC 2010, Saving Mothers Conference 2019, CEFOR, and editor of all these souvenirs of the above mentioned conferences.
It's
And
okay.
no, I need to tell, you're such a qualified person, everyone should know. She has organized hysteroscopy workshop 2017, gynae endoscopy workshop at Garg Hospital, Gorakhpur, and she's the invited faculty in various conferences and CMEs. And she's presented paper in AICOG, FIGO, and UPCOG. She got the Best Paper Award in UPCOG 2020 midterm in endocrine category. And she has the original research publications in the World Journal of Pharma Research and International Journal of Medical Sciences. She is a member of the PCOS Society, GESI, ISCCP, and IH. So welcome, Dr. Amrita. All hats off to you for such a great achievement. Please take the dais and introduce the speaker. Thank you for joining. Yes,
Thank
Amrita.
you. Thank you, Deepti ma'am, for the wonderful words. And at the outset, I would like to thank the Oncology Integrated Society and especially Dr. Deepti Chaturvedi ma'am, who gave me the opportunity to listen to a great orator and on a wonderful subject like preservation of fertility in endometrial cancers. And we all know it's a problem and it is increasing day by day because the era of late marriages and career-oriented women. So they first stabilize their careers, and by the time they realize they want to have a baby, they are nearly 40. And we all know that 5% of endometrial cancers do occur below the age of 40, and they can be treated conservatively. Uterus can be preserved in early cases, that is the stage 1 cases where the myometrial invasion is not there and the vessels are not involved, the lymphatics are not involved. So to speak on this subject, we have a great orator, Dr. Swasti. She is the main consultant gynae cancer surgeon at Max Institute of Cancer Care, Max Super Specialty Hospitals, Vaishali and Patparganj, and Max Multi-Specialty Center, Noida. She is highly qualified and she is having diploma in advanced gynae endoscopy, and also she is qualified surgeon, a robotic surgeon in gynae oncosurgery. She is the convener, Delhi Gynae Oncology Group, member Adolescent Committee, executive member of Delhi Gynae Forum Southwest, and ex-member Oncology Committee, AOGT. She has numerous national and international publications. She is also the editorial board member and reviewer of many prestigious national and international journals. So over to you, Dr. Swasti.
Thank you so much, ma'am, for your kind words. Thank you for the kind introduction, and thank you, Oncology Integrated Society and Dr. Deepti ma'am, for having me here today. It's a topic which is very, very close to my heart, and that's why when you said on fertility preservation in early endometrial cancer, I was thrilled to do so. So there are a lot of things that we need to understand effectively before we actually decide whether we can preserve fertility in a particular woman with endometrial cancer or not. And half of the solution to any problem lies in defining the problem. So I think once you have a holistic perspective of the disease and the tumor biology, only then can you make a concerted effort and decision into decision for fertility preservation, which Dr. Amrita rightly said that, we are having younger and younger women with endometrial cancer. And the real interplay between the hormones, between the estrogen excess the amount of increasing obesity, absent or inefficient progestin signaling, and a lot of metabolic factors at play, obesity, diabetes, insulin resistance, a lot of inflammation at the endometrial target level, and release of inflammatory mediators like cytokines and interleukins and growth factors could lead to a lot of endometrial hyperplasia and cancer. And that's why we're seeing more and more young women who have polycystic ovarian disease and have metabolic syndrome developing endometrial cancer as early as 24, 27 years. And I will just give you a brief synopsis of what is the current standard for treatment, and then we will deviate from that current standard to a fertility preservation. So when you by and large classify endometrial cancers, you have a surgical staging, you have histopathological characteristics, you have a molecular profiling, and you have clinical characteristics which holistically define the tumor and the biology. So, we know that endometrial cancers are of two major gross types, type 1 and type 2. And I'll dwell into that, which is our standard understanding of the disease. And you may have a lot of high-risk histologies also associated. Every cancer has stage 1 to 4 and grades 1 to 3. The important aspects to look at are lymphovascular space invasions, which may be difficult to pick up on a biopsy, endometrial biopsy specimen. And to assess depth of myometrial invasion, you more need to rely on clinical characters if you are desiring a fertility preservation. Otherwise, you would have it on a standard hysterectomy specimen. There are a lot of molecular markers which have been defined into classifying endometrial cancers, like pole mutations, we all know, mismatched repair mutations, just like colorectal cancers, and you have P53 mutations. And then some tumors may have no specific molecular profiling. So you exactly don't know what is the kind of prognosis for these tumors. And a lot of other factors like age, body mass index, desirous of conception or not, what is the ethnicity, socioeconomic status. A lot of microRNA and circulating DNAs have also been investigated, and we are still dwelling on that research. So as I was talking to you about type 1 and type 2 cancers, definitely type 2 cancers comprise of only 10 to 20%, but these are the ones which are more aggressive. These are the ones which are high risk. They have a rapid growth. They have a poorer prognosis. They could be serous, clear cell, mixed mucinous, or squamous differentiations. And they usually metastasize to the peritoneum. Usually P53 mutations are seen, and even HER2 mutations have been associated with most type 2 endometrial cancers. And they are seen generally in older population. You would not see very young women with, and if you do see them, that's really ominous. And one has to look, gravely into the genetic associations. So when you talk about type 1 cancers, these are more common, these are favorable, these are endometrioid varieties or adenosquamous. Maybe with a precursor lesion is atypical endometrial hyperplasia, whereas in the serous varieties, your precursor lesions are serous endometrial intraepithelial carcinomas. So just like you classify pre-malignant lesions of cervix as CINs, we do have pre-malignant lesions of endometrium, which are known as EINs, that is the endometrial intraepithelial neoplasias. And most of these are actually a group of atypical hyperplasias as well. And you do see a lot of microsatellite instability, P10 mutations, KRAS mutations in these varieties. These are the cancers which are seen in younger women. So you have a lot of opportunity to use fertility preservation options in low-risk endometrial cancers. Now, I would also like to talk about how endometrial cancers are surgically staged, because this is critical. We need to assess your clinical stage of disease before we actually dwell to picking up a fertility preservation procedure. So the new FIGO staging talks about myometrial invasion less than 50% or more than 50% in the stage 1A, and only cervical stromal invasion is considered as 2, and the 3 Cs are divided into pelvic oblique paraaortic nodes as C1 and C2, and the rest is by and large similar to the earlier classification. So more than 75% of cancers are picked up early, usually, so in stage 1, and that's the window of opportunity. Now, just some more information about the molecular testing, because this is something, in the next 2 to 3 to 4 months, we may see a molecular FIGO staging coming up for endometrial cancers. It's already being proposed, and it's being debated and considered for final release. So when you talk about the kind of mutations, you talk about, as per the TCGA Atlas, you talk about pole mutations, which has very rich inflammatory stroma. These tumors could be hypermutated genomes like MSI, microsatellite instability, where there is immunoadaptive resistance and a lot of inflammatory stroma. Again, they could be copy number low or copy number high. So copy number low will be very poor inflammatory stroma. They will have some certain mutations, and the copy number high will be the aggressive ones, which are serous-like, which have a lot of CD40 high levels, poor inflammatory stroma, and they will also have some mutations, and I'll talk about those as well. So once you look at pole ultramutated lesions, they will have pole mutations, they will have P10, PIK1, CA, KRAS, MMS. Why I'm saying all this is because a lot of treatment is now going to be based on the kind of mutation that we are going to pick up in endometrial cancers. And we are testing all endometrial cancers for IHC, a lot of intermediate to high risk factors for pole, because that helps us in deciding the adjuvant treatments. And also, these markers have an eminent role in decision for fertility preservation. So the copy number low mutations would be the MMS and the P10, PIK3CA, whereas the aggressive ones will have P53 or HER2-neu type of mutations. So we know that by doing an immunohistochemistry, one could pick up the microsatellite instability and look at 4 major mutations like MLH1, MSH2, MSH6, and PMS2. And these are being done for all our endometrial cancers. If you do not have a pole, do not have a MMR mutation, do not have a P53, it's an unclassifiable endometrial cancer. That means you're not able to pick up a genomic alteration, and you're not able to define this malignancy actually occurred. So endometrial cancers can be either MMR deficient. If they have an intact mismatch repair, then they could be a pole mutation, or they could have an abnormal P53. These are 3 broad areas of testing and decision-making. And when you look at pole mutations, if treatment considerations could be observation or de-escalation, and P53 mutations, all of the abnormal mutations, mutant P53 needs to be treated by systemic therapy. They could have HER2 overexpression, and Herceptin is also creeping up into endometrial cancer treatment. Whereas if you have non-specific molecular profiling, then you could give endocrine therapy if you test for an ER positive, and most of our endometrial cancers will be ER positive. So immune blockade mechanisms are useful for mismatch repair and also identification of Flynn syndrome. Now, similarly, I've just tabulated how low risk to advanced metastatic tumor, abnormal molecular profiling, and a nutshell about the current standards of endometrial cancer treatment. The stage 1A, grade 1 or 2 LBSIC, we usually have a surgical staging unless and until you detect it in an advanced metastatic situation. The primary treatment, is a systematic surgical staging. And based on what you find, you decide for adjuvant treatment. So if you're having an endometrial biopsy and you're doing a metastatic workup, you understand the pre-op risk assessment and decide the extent of surgical staging. So you add a mentectomy, appendectomy, peritoneal biopsies, and other things like an ovarian cancer in type 2 endometrial cancers, which are the high-risk ones, which will be like serous, clear cell, and other things, right? And now we have to understand how we have to take a decision to preserve. So we come to the criteria of fertility sparing therapy in endometrial cancer. They should be well differentiated. Endometrioid adenocarcinomas grade 1 on DNC, which should be, or endometrial histological assessment, I would say, because hysteroscopy DNC forms the gold standard of diagnosis, and it should be confirmed by an expert pathology review. So the second point is that you must only target these situations to a situation where there is no myometrial invasion. So sometimes for people, it's very difficult to understand myometrial invasion on a transvaginal ultrasound. So an MRI is a preferred modality of treatment, preferably with contrast. And it is always better to do an MRI with a contrast, and absence of suspicious or metastatic disease on imaging. That's very important. It should be a uterine confined disease, preferably confined to the endometrium, no myometrial invasion, grade 1 tumor, and no contraindications to medical therapy or pregnancy. There should be no medical condition which predisposes her life to a risk if she becomes pregnant, and the patient should undergo a counseling that fertility sparing option is not the standard of care for treatment of endometrial cancer. It is just a deviation from the standard of care to buy time to allow the completion of childbearing and then go back on the treatment, which is the standard of care, which is the surgical treatment. So it is just a deviation from the usual standard of care. And what are the salient things to think about when you're doing this selection? This is a very, very important selection. Otherwise, your results will not be good. The patients and the women will really suffer because of disease. So genetic counseling and testing may be needed for selected patients if they have a very strong family history and you do identify a Lynch syndrome or something, and then it becomes very, very tricky to understand. Comprehensive molecular profiling is important. Once the childbearing is complete, or if the medical therapy fails, or if progression occurs, they have to step up to the surgical staging that should be consented and counseled clearly. Fertility sparing therapy is not recommended for patients with high-grade endometrioid adenocarcinomas, uterine serous, any type 2 pathology, clear cell, carcinosarcomas, serous cancers, or high-grade tumors. Now, grade 2 becomes a little gray zone. There are sporadic studies where they have tried this for grade 2 endometrioid carcinomas with good results. But standard is grade 1. So the recommendations all talk about grade 1. All the guidelines talk about grade 1. And that's how you will sort of utilize MRI to understand the tumor size, myometrial invasion, lymph node assessment, extrauterine disease, and then take your calls. So what is the treatment which is given? Medical treatment given for fertility preservation in endometrial cancer. Now, when you're talking about endometrial cancer, your ovaries are normal on the MRI. Still, you would not want, there would be questions at this point of time. People would be thinking that, can we stimulate the ovaries? No, with an endometrial cancer, do not stimulate the ovaries. First, clear the endometrium of disease. So if you stimulate the ovaries in the presence of tumor, these tumors are usually ER/PR positive. You can do an ER/PR receptor status on these tumors. Even if they are ER/PR negative, they will be very rare that you will have a ER negative endometrial tumor. And even if they are PR negative, you still can give progestin therapy. The results may not be as good as if they were PR positive. So we do give continuous progestin therapy. We use megestrol acetate. I use megestrol acetate particularly. The other options are very high doses of medroxyprogesterone acetate, or use a Mirena or a levonorgestrel intrauterine device. Now, usually what I use for my clinical practice is 160 milligrams of magistral acetate every day. I give it continuously for 3 months. The last woman I treated was a 33-year-old a lady married for 5 years and was trying for pregnancy for the last 6 months. And, she had some irregular spotting, which she ignored. And finally, her obstetrician and gynecologist actually did an endometrial biopsy, which a hysteroscopy DNC. Because of this irregular spotting, there was a polyp, suspected polyp, and which had a malignancy. It was a well-differentiated endometrioid adenocarcinoma. So, we start after an MRI. We do an MRI for assessment. MRI showed no myometrial invasion, and I did a receptor status. She was ER/PR positive, HER2 new negative, P53 negative, IHC MMR was okay. There was no deficient this thing, and so all the marker to her favor. Now it is very evident that we review an oncopathologist reviews these slides, because the kind of decision that you're taking, where survival is at stake at one point and treatment for fertility is also important, you need to be very, very confident. And I reviewed it at our center, and we went ahead with treatment. We give 160 milligrams per day of magistral acetate continuously for 3 months, and then we do a subsequent hysteroscopy DNC every 3 months. So the maximum that you could go is actually about 9 months. It's not recommended to go beyond 9 months. That means 3 sessions, of hysteroscopy you could do to assess reversal of malignant change or atypia. If you have an atypical endometrial hyperplasia, the protocol is the same. Now, our recurrence rate for progesterone, on progesterone therapy is about in 1/5 patients, and it's after an average of 23 plus months. So you have a window period of about 2 years where she could complete her pregnancy, childbearing, and then you can take her on the path of surgical staging. So the shortcomings of progestin therapy in such high doses could be abdominal cramps, depression, dizziness, headache, and nausea. And she should have no history of breast cancer, stroke, MI, pulmonary embolism, DVT, or smoking. These are contraindications to progestin therapy. Women with history of any of these should not be put on high doses of progesterones. So NCCN says that during progestin therapy, every 3 to 6 months, you do endometrial sampling. I would say a hysteroscopy DNC every 3 months, because you visualize the endometrial cavity as well, and you understand repeated DNCs could lead to synechia formation also, which could be handled on your last hysteroscopy. So same thing as I said, after 6 to 12 months, you switch over to a surgical staging. There are studies which have taken place by use of LNG intrauterine device. It can provoke a high local progesterone intrauterine levels, and there are some studies which say that they're not very conclusive. But we have some meta-analysis which says that pregnancy outcomes may be worse in patients where you only treat with an LNG IUD. If you add LNG IUD and add some amount of oral progesterones, these women respond better and your results improve, pregnancy rates improve. So, you choose young women, have a low-grade endometrial cancer, insert an intrauterine device and give some oral progesterone. Combined treatment is usually more successful to leave levonorgestrel IUD alone. But the first choice is obviously high doses of progesterone. So some people have even given GnRH agonists along with LNG IUDs, and satisfactory pregnancy rates and low recurrence rates have been observed in meta-analysis and some Russian studies, and they've had complete response after about 18-19 months, which is quite a long period of time. Then you could do a hysteroscopic resection of the tumor, actually, and resect the tumor and then give progesterone therapy if you're dealing with a large polypoidal lesion or something like that. Now, hysteroscopic resection could proceed with a LNG IUD. It has lower relapse rates than progesterone alone and similar pregnancy rates. So I will just take you through some guidelines and then we could probably take up questions. Number one, these women have to be handled by a joint team, multidisciplinary team of gynae-oncologists, fertility specialists, pathologists, and radiologists. The lady whom I was just talking to you about this case, after I did hysteroscopy 3 months after giving her continuous migestrol acetate 160 mg per day, there was complete resolution of atypia and malignant change in the endometrium, and now she's currently undergoing assisted reproduction IVF. I just hope that she conceives. My last patient also had first successful IVF, and she has a 3-year-old baby now. So we do have good pregnancy rates in such kind of situations, provided we do a good patient selection. Another woman, when she came to me for fertility preservation, her tumor was grade 3. And when we investigated, she had Lynch syndrome and she also had P53 mutation. So, these kind of tumors are not the ones which deserve a fertility preservation. So the presence of concurrent or metachronous cancer has to be determined and excluded. So you have to do a good thorough examination, breast examination. You have to look entire abdomen, and gynecological assessment has to be comprehensive. Patients have to be informed about higher risk of persistent or recurrence as compared to women who are not opting for fertility preservation. We have to tell them this is not standard of care. And in women who've got Lynch syndrome, we have to individualize. Whether we have to do other markers, we have to understand, we have to do a risk stratification, and then only take a call jointly. So initial review has to be really good. Sometimes we see people have reported as grade 2. And once we review, grade 2 is a little gray zone, but once we review, they are actually grade 3 or sometimes only grade 1. So in those situations, our decision-making, it's always better to be on the safer side, have 2 opinions, have an expert oncopathologist looking at those slides, not only the slides, the blocks as well. So sometimes, it is always going to help us in taking the right decision for the woman. Now, we always do a G1, G2, G3. We don't talk about well-differentiated moderately. We talk about a good grading system, which is a standard for reporting. And use of IHC is very, very, is a good modality to utilize in such situations. So even the guidelines say, these are 2023 guidelines, fertility sparing treatment for grade 1, stage 1A without myometrial invasion, without risk factors, is a good situation. And evidence for grade 2 is limited. So fertility sparing has to be done on a grade by grade, on a case to case basis. And we would prefer doing a hysteroscopic guided biopsy rather than a blind biopsy where you could miss or where you could not sample so much and you not visualize, because subsequently also it is always better to do a hysteroscopic reassessment after progestin therapy. So it's better to have a hysteroscopic assessment prior as well. So pre-op assessment or pre-fertility preservation assessment by standard MRI protocols is a good modality to use. We don't use CT to see myometrial invasion, and CT involves radiation exposure. You have a young patient, wants fertility. We don't want to do all that unless and until we understand that, or we fear that you have a possibility of a metastatic or an extrauterine disease. Then we could use CT to understand the extent of metastatic disease. And adnexal involvement is best assessed by MRI as well as transvaginal ultrasound. So these 2 modalities are good enough to do. Now, as I talked about the doses of progesterone, similar sort of mentioning is there in the guideline. You have a good amount of cases where you could do a hysteroscopic resection prior to taking them up for fertility preservation. And the duration of treatment is initially 6 to 12 months. Maximum time to achieve complete response should not be more than 15 months. So you can't just be giving progesterones and continue to go on for years altogether and waiting for the tumor to grow. So weight control is very important. And what I tell all my patients is that please do lifestyle changes right from day 1. there is some metabolic issue, you have some sort of a predisposition to not exercising and eating unhealthy, so spare that. Have a healthy lifestyle, improve and work on it right from day one. It really helps. The more you exercise, the more you eat sensibly, you improve your lifestyle, de-stress, have good sleep. It will help women to get, response to progestins also better. So it's important for patients who are not willing to conceive straight away. You could give them a 3-month interval from assisted reproduction to the last biopsy, which said everything is clear. But we have to tell them that, cancer could come back, and this is the window period of opportunity. So that's why a very, very in-depth counseling is important once you're making your, initial judgment and initial case selection. So they have to be given a good information about all the aspects of care and possibilities, and then only they can take the right decision. So for pregnancy, again, we have to have a close surveillance by a multidisciplinary team. And once they conceive, they have to be looked by a high-risk pregnancy unit as well, and monitored very well during. It's a precious pregnancy. So once they complete childbearing and lactation, we can put them on the definitive surgical staging pathway, and completion surgery is recommended, where you could or could not remove the ovaries, because these patients are young. They're either in their late 20s, early 30s, or mid 30s. And usually most of them are less than 40 years. In women over 40 with a low AMH, we don't want to tailor them to the path of fertility preservation, because as it is, they will have a low possibility or low chances of conception. So ERPR status is an important thing, but negative ERPR is not a contraindication for fertility preservation. Again, molecular profiling is important, and mandatory is to exclude Lynch, and mandatory is to do an IHC MMR testing. If Lynch is identified, we do a colonoscopy also in these patients because of associations with colorectal cancer, and go into in-depth genetic counseling and testing. If they have a high P53, we don't take them for fertility preservation. The guidelines also say the same. So to conclude, I would like to say that women of reproductive age experiencing endometrial cancer require conservative management and counseling for fertility sparing options. The management of young women with endometrial cancer and atypical hyperplasia, it varies amongst clinicians. Use of progestin leads to good results in treating early endometrial cancer and is very useful for fertility preservation. However, optimal treatment is still debated. We don't have consensus, but we do have clinical experience and a lot of publishing of data on that. So furthermore, for fertility sparing management should not be restricted to infertility as only. So if somebody has one child, has the desire to complete a family, then also we can offer them fertility preservation. Operative hysteroscopy should be the preferred endometrial sampling method because of its association with a higher remission, and guidance for managing conservatively young patients with endometrial cancer should be provided, but it should never replace the individual approach for care and management, because every woman will have a different character, every tumor will have a different character, and every woman and couple will have different needs and expectations from treatment and from life. Thank you so much for your patient listening and attention. I would be happy to answer questions if any.
Excellent talk, Dr. Swasti. And you covered everything, especially the management part. You did very well, and everything is clear. I think everybody would be benefited. You took the conservative part, you took the operative part, also the extended operative part, right from ovamentectomy, appendectomy, etc. So it shows how much depth you have, depth of knowledge in this subject. Thank you so much.
Thank
So
you.
over to audience for the questions.
Yes, Ritu, are there any questions? You can paste them.
No, ma'am, we haven't received any questions so far. If I'm getting, I will post it.
Okay. Has Dr. Surita Karim joined?
Yes, yes, I can
Yes,
see her.
ma'am. She has joined
Yes.
and she has also sent me
Hi,
the link.
good evening. Yeah.
Good evening, ma'am.
So would you like to
Hi.
add She's a brief introduction? She's the owner of Star Hospital and she runs an IVF uh,
Center.
center also, known
Suffer.
as Safal Test Tube Baby Center. And I would like to ask Dr. Surita Karim to give a few tips on fertility preservation, like in those cases who have endometrial cancer or any other. So, how would you preserve? How would you go about in preserving the oocyte or ovary or embryo? What you do? Because I know you are doing an embryo transfer and all those things. So let's have your view.
Thank you, Dipti. And it is a very, very nice talk. I witnessed and I was lucky enough to join because of the late information. And Dr. Swati has given a very comprehensive overview of the endometrial hyperplasia and the endometrial cancer and the need for preserving the fertility, because as we all have known that the patients now are wanting to conceive at a later age. And so the window of fertility is getting smaller and smaller. And in that time, if somebody is diagnosed with the atypical endometrium or with the endometrioid cancer, then it becomes really difficult and challenging for the obstetrician, for the practicing oncologist, as well as for the infertility specialist to, find a way forward for such women so that we can help them. But the good thing is that in the last so many years now, the last 5 or 10 years, I would say the thrust is now on fertility preservation. Once some oncological diagnosis is made, sometimes these are early cases, sometimes these are late cases. Of course, the late cases, we cannot help them much. But in the early cases, then we have seen that I am really happy that under your guidance and leadership, Gorakhpur is getting this oncological dimensions, so that we have been getting patients who have been referred for fertility preservation. Like Dr. Swati showed in her slide, I'm sorry I'm not able to share any videos right now, but if Ritu could have downloaded something from the YouTube, maybe she can show us on the screen. So the
Ritu?
fertility, have you downloaded? If something is available, everybody can get an idea, because
Yes.
most of us who are doing laparoscopies, we know that in a simple laparoscopy, it is very easy to do a ovarian, it's very easy to take out the ovarian tissue, because you are using the 3 laparoscopy ports, putting in the trocar and doing the 2 other ports there. And
Okay,
with the
just a
grasper,
minute, please. I think so. She has downloaded. Ritu, have you?
Yes, ma'am. Yes, ma'am.
So
yeah,
you
we
just
can see the
relay it.
technique of how
We
can see the
Yeah,
technique
and
of
Dr.
how they're
Karim
doing
will.
the.
You
Okay,
I
explain.
will
So-
run you through it. Yeah,
Okay, ma'am. Shall I just share this screen right now?
Sure. Sure.
please
Okay,
do
ma'am.
it.
Just give me a minute.
And not only for the females, I also want to say that for the males also, we
Yeah.
can do the semen cryopreservation. Yeah. So once we put the laparoscope inside the abdomen,
Transplantation are procedures used for fertility preservation in patients of all ages receiving high-risk gonatotoxic therapies. This video reviews the different surgical procedures that can be used to perform ovarian tissue cryopreservation and transplantation. A tiny needle is placed through a small incision in the belly button and used to inflate the abdomen. The needle is removed and an instrument guide, also known as a trocar, is placed through the incision into the abdomen. A camera is then inserted and is able to watch 2 additional trocars as they are placed in the right and left lower portion of the abdomen. The surgeon looks at structures in the abdomen and around the ovary to make sure the surgery can be safely completed. Generally, for small children, the entire ovary is removed. but for older girls and women, it is possible to remove only the outer layer or cortex for preservation. The ovary is grasped and a surgical energy device is used to separate the ovary from the fallopian tube. The ovary is then placed into a pouch and removed from the abdomen. If only a portion of the ovary is being preserved, then laparoscopic scissors are used to dissect the cortex from the rest of the ovary in strips. The tissue is then placed in a pouch and removed for processing. The surgeon confirms the surgical site is without bleeding and completes the surgery. If the whole ovary is removed, the specimen is sent to pathology for evaluation prior to tissue processing and freezing. The ovarian cortex is then dissected from the ovary, cut into 1 to 2 centimeter tissue strips, frozen and stored for future use. When the patient is ready to attempt pregnancy in the future, the small ovarian tissue strips are thawed and placed back into the pelvis by laparoscopy. In this first technique, scissors are used to make a 2 to 3 centimeter incision in the peritoneum or lining of the abdomen. The thawed ovarian tissue strips are then placed into the space and sealed. Another technique involves placing the ovarian tissue strips directly on the remaining ovary and suturing the tissue in place. The size of the ovary will determine the number of strips that can be placed using this technique. The patient is typically able to be discharged to home the day of the surgery. After transplant,
I think that will be enough.
monitored through blood work over several.
Yeah.
It
So
was
we
really
can see very easily how it is very easy to remove the ovary. We can either take out the whole ovary or we can take out mostly where we are getting the adult patients, so we can take out the ovarian cortex. The important thing is that once we remove the specimen, usually if we are doing it at our center, because we have the lab, we can put it in directly in the media, or we can just transport it dry to the lab and then cut it into pieces and then do the vitrification technique. Mostly the vitrification technique is used either for the oocyte or for the tissue. So either it is a spermatic tissue or it is the ovarian tissue. Now the vitrification technique is much better than the slow freezing technique. Usually in the last decade or so, I think more than 15 years now, initially they were doing the slow freezing technique, in which gradually the temperature of the tissue used to be brought down, but that caused a lot of injury to the tissue. So when we were trying to reuse the tissue or thaw it, at that time we did not get good results. The new technique of vitrification was brought by Kitazato in Japan. And even now the Kitazato media is being used for doing all the vitrification techniques. So as we know, vitrification means converting into a glass. All the cytoplasm and the nucleus of the tissue gets converted into a glass-like structure, and that protects the DNA from getting damaged. So then once we cut the tissue into small pieces, we have special media. Into 3 stages, we put it into the media. There are 3 kinds of media in which we have to do the subsequent placing of the tissue, whether it is the direct tissue or the oocyte or the sperm. And once it is done, then it becomes vitrified. Vitrified means it becomes like a glass ball. Then it is loaded into the cryo pipettes. The pipettes are provided by the companies, and we can load these vitrified embryos or the vitrified oocyte or the vitrified tissue into the cryolog, and we put it into the liquid nitrogen tank, which we have at the center. And in the tank, this tissue gets stored, and we can store it for a number of years. I mean, the minimum is 5, but the maximum, I don't know, they have still not come out with a definitive study. But I think it is now safely, we can say for 10 years, we can preserve that tissue. And all this is being done. The only thing is that the people who are getting the patients directly, the doctors, they have to be sensitized to the fact that this is also an important part of the therapy. The patient has to go for fertility preservation. And so just because she has been diagnosed with a malignancy does not mean that her fertility should be hampered. So that is all that I have to say. Now, anything else we can discuss, you and Gwen.
Yeah, very rightly said, Dr. Kareem. And we are really, it's a pleasure कि गोरखपुर में हमारे पास ऐसी lab है, ऐसी technique है. CM city is really improving and growing. So is the fertility consensus and techniques. So Dr. Swasti, you are there, no?
Yes, ma'am.
So I was just asking, like you said, we are not removing the ovaries in early stages. We are just treating by progestin and Mirena and all that. Early uterine cancers. Suppose it is third or fourth stage, then what she has shown through the video, will this be possible? Like after the treatment,
No,
we
ma'am.
can.
So if there is anything beyond stage 1A, then fertility preservation is not an option. And that's why we are doing an MRI. See, at nexal metastasis, agar hai, to it will become stage 3A. So it is not an option. So if the ovaries are involved, there is a concern. We cannot even do ovarian cryopreservation. We can't do anything with that. We can't stimulate the ovaries. It's an advanced stage. We can't stimulate the endometrium. We'll have to go by a
She has
radical
said,
surgery.
excuse me, she has just
Sorry,
said the cortex will be preserved. I mean, they are not stimulating
ma'am,
it. They're just
if
preserving the
you
cortex.
have a surface disease, if you have an advanced endometrial cancer, then we don't do ovarian tissue or ovarian oocyte or embryo, anything. We don't do fertility preservation as an option at all. So only for stage 1A, fertility preservation is an option, that too grade 1. Grade 2 plus minus, that we will decide on only on molecular markers. And if stage 1A, grade 1, type 2 cancers, high-risk histologies or abnormal mutations, then also we will not do fertility preservation.
Yeah, somewhere
So
I
we
read.
have a lot of molecular testing, which is going to be useful for us to understand which tumors will be aggressive. So there was a time 10 years back when I used to decide my patients for fertility preservation. The only thing that I had in hand was ERPR. We were not even having so many IHCs available 15 years back. Now we have a horde of IHCs and molecular markers which tell us exactly which this tumor has a good prognostic value or a poor prognostic value. And wherever you have anything which leads to a poor prognosis, like a HER2/neu or a P53, we are not going to, or a very high Ki67, we are not going to take these tumors for fertility preservation, because you will fail. You will fail your treatment immediately. You will fail within 6 months. You will have disease all over, or you will have progression of disease.
I wanted to actually, what I wanted to understand was that this fertility preservation is actually because I have patients who have come in with breast cancers. So for breast cancer, before going for chemotherapy, sent for.
So there is a window of opportunity in breast cancer.
Yes.
And as we always tell our fellow oncologists and colleagues, that you don't need to have a particular time of the period which is important. Random start protocols are there. And actually, gynae oncologists form a lot of bridge between the IVF specialists as well as the other oncology people, because they have lesser knowledge of fertility preservation. Now these things have started coming up in the last 4-5 years, when we people have started talking about so much of fertility preservation. People have started realizing. There was a time 15 years back when we were I was seeing 19-year-old girls and they were coming and asking me, CA rectum
Connection lost.
Weak connections.
Connection loss. Yeah, I have a patient of mine. I mean, she's a friend's daughter-in-law. I delivered her, and after delivery, after say 2 months of delivery, she developed a breast lump. And while we did the lumpectomy, there was enough time for me to do her fertility preservation. But since because those things were not talked, and I had already started my infertility center, we were doing vitrification. But it never crossed my mind also that we can do something for her before she goes for chemo or radio. So that girl is now,
again
she
in
has
breast
son who is
cancer. if you have a genetic issue, if you have a TNBC, you have a triple negative breast cancer, you have a poor prognostic situation where you can't actually allow. So that is why I said it has to be a joint decision, joint consult. We sit together and talk to patients, because one thing leads to another. We have to connect all the dots. You can't say, okay, I have told you this, now go and meet this person. Once you sit with the patient together and the couple together and the families together, there will be a lot of aspects to be discussed. Lot of aspects. In fact, I take about 5 to 7 sessions of, sitting together and talking and then taking a decision.
Yes. एक तो familial है, Lynch syndrome वगैरह. So how can you allow first thing to counseling
Lynch,
if she's
very
willing
limited.
to,
I don't take up patients with Lynch usually for fertility preservation. It's a big challenge because you have other malignancies, particularly colorectal associated.
Yes.
So I had a lady in that. The decision was simple because it was a grade 3 malignancy. Grade 2 reported outside. We reviewed. It had a grade 3 malignancy. It was an endometrioid, but Lynch was positive. She had an MLH6 positive, and P53 was positive. So it's very difficult to take these patients up for fertility preservation. So there is one thing that we always tell them. There are two aspects. There is a balance between survival and fertility preservation. Wherever the survival balance rises up, we have to go towards survival. And wherever we think, okay, we have enough situations where we can take this chance, we can, push this for about 1.5 to 2 years, we will be able to take up the fertility preservation aspect on a higher scale. So it's a very, very critical balance. We have to talk about risks and benefits of both approaches. And I usually make algorithms, or, we write and discuss every aspect and say, okay, if this is the grade, what is the possibility? These are the factors in favor of fertility preservation. These are the factors against fertility preservation. What is the likelihood of tumor behavior in these situations? And then only we once you start discussing on those lines, then gradually, the patient and the family and the couple will be able to understand, because they are so fazed by the word cancer. Imagine somebody at 33 working.
That's what I was saying, that in that case, my patient, now I meet her almost every month or so at some party or the other. And she always tells me, Auntie, aapne mujhe fertility preservation ka bataya nahi tha, I would have got it done. I said, I'm so sorry, baby. I did not have that, the vision to, make it clear to you that maybe you can do that. But still, she has got a son.
So in fact, where we can't offer fertility preservation, also we document that we can't offer fertility. This is not an option for you, because these are the reasons against picking up a fertility preservation. That is very important, because 2 years down the line, when you're treated of cancer and you are going back to your normal life, you start thinking, oh, nobody told me about this. I could have picked it up. So we tell them why we are not choosing this pathway. These are the things which prevent us from choosing this pathway.
Yeah. That is a very good way. You have given us a very good insight into this thing, that how to do a joint counseling and make the patient understand that these are the reasons why
for the woman to participate. Now the time of judgmental treatment has gone away. We are all practicing participative medicine. So once the woman and the family and the couple together, they participate in making joint decisions. So I tell them, we are all one team only, na? We're not you and me, or us and you. So we are all together in that process of making the right decision. And it's our responsibility as clinicians to actually impart the right knowledge to the patients and their families, so that they can take the right decision. Informed consent is all about doing that.
Yeah, very nicely said. And there's a doubt where I read somewhere, in cases of fertility preservation, what they do is they give some medicine like Zoladex. This is what I had read, to spare the ovaries, and then they go for the chemotherapy.
No, Zoladex is a this long-acting agonist. So
GnRH agonist.
GnRH, So that is only suppress the hypothalamic pituitary axis and do nothing for the fertility preservation. Is not. That is the part of the protocol.
No,
Ma'am,
they are
there
saying
is
ki
one, to
prevent
answer your question,
ovulation.
can I take your question? Yeah.
Yes.
When you give GnRH agonists, there are studies which talk about the fact that it arrests the ovary in the primordial stage. So whenever you start chemotherapy, if prior to the start of chemotherapy you give GnRH, then they will arrest the ovaries in the primordial phase, and they will, protect. It will act as a oocyte protector. And that is the only rationale for using. There are mixed studies. Some studies say it is useful, some say it is not. But anyway, it is not going to do any harm. That can be done. Particularly, we do that for breast cancer patients. So many a times for breast cancer patients, we do that. See, endometrial, the way of fertility preservation is different. Now, in ovarian, the situation is absolutely different. To pick up a early ovarian cancer is in itself a challenge. Okay, and
Yes.
fertility preservation in ovarian cancer is very, very critical, because if you do not morcellate, if you do not cut the tissue. I just recently operated a 15-year-old girl. She had a 39 centimeters ovarian mass, 39 centimeters. And she had come for summer holidays to her uncle's house. And that uncle, I mean, the mother is not, thinking about it. The uncle said she's abnormally gaining weight over the abdomen. Let's go and get an ultrasound done. Mother is thinking she's a chubby girl. Like, kids are chubby, they're reading, studying. She's in 11th standard. And they're thinking that she's gaining weight over the abdomen. So this is a very common situation. Now, this girl has a borderline mucinous tumor. The mother asked me, can we do a laparoscopic removal? I said, absolutely not. I will not do, even if it's a benign thing, I will not do. We have to understand that cystadenomas are also precursor lesions of borderline. We have to also understand that if we are dealing with a mucinous tumor and you have mucin all over you, we know that adenomyosis also can lead to implants if you morcellate. So similarly, you can have mucin implants also on, which may sort of progress later. Those things will come up. It has to happen. So later on, and there were 2 solid nodules. Frozen section says I did a unilateral salpingectomy. There's no way you could do a cystectomy for a 39 centimeters mass. It is a borderline mucinous tumor. So with ovarian tumors, the challenge is how intact are you removing it? Who is removing, where it is being removed, frozen is being done or not, whether the person who's doing it has an oncological perspective. These are the challenges. I've seen people doing borderline tumor removal and morcellation, and women dying within 2 to 3 years of those episodes, because we know that morcellation will change the prognosis of disease. It will lead to spread, it will lead to implantation, and it will lead to further progression, which will be accelerated. I have seen women having adenosquamous or carcinosarcomas as recurrence, local recurrences, abdominal wall, rectus sheath recurrences. And then, women having lung mets within 3 to 4 months of that. So, these are situations which can be absolutely avoided. So fertility preservation in ovarian cancer is totally dependent on how it is being handled. In any situation.
So really good. We had fertility preservation from all aspects of gynecological cancers. We called you for one, and we had many. So nice of you and so kind of you. Dr. Amrita, would you like to conclude?
Yes, indeed. It was a wonderful session and I got to learn a lot in this. And Madam Kareem, your video was very, very nice. And I didn't have the idea of the cortex preservation, the way it was shown in the video. And Dr. Swasti was brilliant in her talk and the answers to the questions. Thank you so much. Thank you, Dr. Deepti, for making a part of this wonderful webinar.
Thank you,
Thank
ma'am.
you, Dipti, for
Thank
including
you,
me.
Dipti, ma'am.
Thanks all of you. And it was real pleasure to have a discussion on this important topic of ovarian preservation, fertility preservation. And sometimes I think, can we do surrogation or what in like ovarian preservation? And if uterus is lost, then go for surrogation. That Swasti will answer later on. We will have a talk. And so for now, we conclude it with thanks to all the participants of Oncology Integrated Society and Dr. Karim, Dr. Amrita, Dr. Karim for her readiness and for steadfastness to join this and help us all with the video so soon with a few seconds of information. And really, it's a great pleasure for you to be so sporting. And Dr. Swasti, you are excellent, you are brilliant, and your talk was very informative, elaborative, crisp, and what not to say. Still, we have so many lacunae and so many gaps in the knowledge which has to be bridged up by such type of webinars again and again. And thank you, Swasti, again and again. Thank you, Clarinet, technical support, and thanks all again for lovely audience to be there with us. So, bye-bye and good night for the timing. See you
Good
in
night.
the next
Good night.
webinar.
Thank you,
again.
Very nice.
doctors, for sharing such valuable insights. And thank you for extending us the opportunity to host the session. And I hope you had a seamless experience. So with all your due permissions, everyone, I am closing the session for today and looking forward to hosting you again very soon. Till then, stay safe and healthy and have a nice day to all. Thank you.
Okay, thank you.
Thank you. Bye. Bye.
Thank you.